Hello. Hello.
Hello,
Yeah, good afternoon. How are you?
I'm fine, and you?
Yeah, I'm fine. Thank you for joining us today.
You're welcome.
All right. I think we just have 1 more minute and then we'll start.
Okay.
Yeah. I think you are all right with all the settings, right?
Um, yeah, yeah.
Okay. I'll just let the group know now that we are about to start.
Okay.
Ignore the Emmanuel Oladeji you are seeing. He's the owner of the account I'm using to create the program session. So I'm just impersonating him.
Okay.
Yeah. Let's see. Yeah, some people have joined. Okay. Okay, I think people are joining already, so we'll start now. Good afternoon, everyone. My name is Jubril Babatunde. I'll be moderator for today's teaching session, and it's essentially about imaging in orthopedics. And today with us is consultant radiologist Dr. Nadine Rizkala, who will be taking us through the session. So the way the program runs, it's just we are the only two people that will be visible. Others, when they have questions, they can just send them messages. I will let you know about any questions or clarifications they have. Okay, and the floor is yours. You can share your screen and take over the presentation. You are muted.
Thank you very much. Thank you.
Yes.
Good afternoon, everybody. My name is Nardin Rizkala. I'm a consultant radiologist working at Shrewsbury and Telford Hospital. Now we're going to have a short talk about essential imaging for T&O. There are some basic radiology principles we're going to look through. This is an AP view of a finger. This patient presented with trauma, and when we look at the X-ray, it looks satisfactory. Satisfactory alignment, no obvious fracture lines. So we would normally call this as a normal X-ray. But then, when we look at the lateral X-ray of the same finger, we find that there is significant dislocation at both the distal and proximal interphalangeal joints that was totally invisible on the AP X-ray. So the first lesson is never look at one view. When you're examining a bone or a joint, you have to check the two views because some significant abnormality may be totally occult on one view. Radiographic signs of fracture. Most of us know that the fracture line is just a black or a lucent line traversing the bone, but there are other radiological signs of a fracture. This is the typical appearance that we all know, a black or lucent line that traverses the bone, which is a fracture. But always remember that fracture lines can also appear as white or dense lines. In this fracture, for example, because there are overlapping bones, so it appears as a white line instead of a black line. And the impacted fracture is the same because overlap of the bones cause a dense or a white line instead of a black line. So always remember that fracture lines can be black or white. There are other signs of fractures, for example, in this patient. When you look at this radius, it is fractured, but you cannot see the definite lucent line that we're used to. But there's something else that's obvious on this X-ray, is that look at the distal ulna. The cortex is smooth, curving smoothly. But at the distal radius, that's not the same. There's sharp angulation or stepping in the cortex on both sides, and that's an impacted fracture of the distal radius. That's a pediatric patient. So basically, the children bones are different from adult bones in that they are slightly elastic compared to other bones, which means that they could bend instead of totally break, unlike the other bones. So in this patient, for example, there is focal buckling or bulging of the cortex instead of the normal lucent line we're used to see on fractures. So this bulging of the cortex on the AP X-ray and on the lateral X-ray denotes a type of fractures in children called torus fractures. Sometimes on the X-ray, there are no obvious fracture lines, but there are some soft tissue signs that would signify that there's an underlying significant injury. For example, this lateral X-ray of the elbow, the humerus looks satisfactory, radial head, ulna, no obvious fracture lines, no obvious dislocations. But there is a soft tissue sign that would signify that there is a significant injury here, which is the fat pad sign or the sail sign. What does that mean? That's the fat pad anterior to the humerus, and that's the posterior fat pad. It's slightly lucent or blacker than the adjacent soft tissues. Normally, we can see maybe a very thin fat pad anterior and parallel to the cortex. But when it's elevated like a sail, that's why we sometimes call it a sail sign, and posteriorly it's elevated, that means that there is some joint effusion that's displacing the fat pad away from the humerus. Joint effusion or hemarthrosis in the elbow would signify that there could be a significant underlying fracture. So when we look at the AP X-ray, if we looked carefully, we'll find this crack or this fracture within the radial head that would explain the joint effusion on the lateral X-ray. Describing fractures. What does describing fractures mean? It means that if you are in an A&E department and you're examining a patient with a fracture and you're talking to your consultant on the phone and you want to describe the X-ray appearance, describing a fracture means that when you describe the fracture accurately, the consultant on the phone, despite not seeing the X-ray, he would imagine how exactly the fracture looks like. So how can we accurately describe fractures? Site. It's which side, right or left side, name of the bone, which bone is it, and which part of the bone is it. Let's see some examples. So that's a fracture. But which side is it? It's the left side. What bone is this? That's the humerus. So it's a fracture of the left humerus. Which part of the bone is broken? Is it the proximal part, the mid part, or the distal part? It's the mid shaft. So this is called a fracture of the left mid shaft humerus. Another example, that's the right femur, and that's the fracture of the right femur. It's the right side and the femur bone. Which part of the femur? It's called the proximal part. And this part specifically has got a name. The fracture runs between the greater trochanter and the lesser trochanter, and it's called an intertrochanteric fracture. So this fracture site is called right proximal or intertrochanteric fracture of the femur. When we come to hands and feet, it's a bit complicated because if you're looking which side, it's the left side, which bone, it's the phalanx, which part, it's the proximal part of the phalanx. But then we have 5 fingers in each hand. Which finger is it? And in each finger, we have 3 phalanges except the thumb. Which phalanx is it? So we have to be more accurate. So it's the left hand and the proximal phalanx of 2 fingers, which is the second and the third fingers. We start counting from the thumb. So this is the second and the third fingers. So it is fracture of the proximal aspects of the proximal phalanges of the second and third fingers of the left hand. That's how we accurately describe fractures of the hands. Direction of the fracture. The fracture can be either transverse, oblique, or spiral twisting around the bone. That's a transverse fracture, that's an oblique fracture, and that's a spiral fracture that twists around the bone. Fragments. Is it a comminuted fracture or non-comminuted fracture? What does that mean? So in this fracture, there are only two fragments of broken bone, 1 and 2. So this is not a comminuted fracture. But look at this diagram. It means that 1, 2, 3, more than 2 fractured fragments is called a comminuted fracture. That's an example. It's 1, 2, 3, and possibly 4 fragments. So that's a comminuted fracture. Displacement. What does displacement of the fracture mean? This diagram shows a fracture, but the two fractured fragments are still aligning together satisfactorily on the AP view. But look at this fracture. There is some displacement, which means that there is no adequate alignment anymore between the fracture ends. How do we describe the displacement? That's an AP view, and that's medial, and that's lateral. So, do we say that there is medial displacement of the proximal end, or do we say that there's lateral displacement of the distal end? The agreement is that we always describe the displacement of the distal bone, which means that this fracture has got lateral displacement because the distal fragment is laterally displaced. And on the lateral view, that's anterior and that's posterior. That's adequate alignment with no displacement. But look at this fracture. The distal fragment is posteriorly displaced compared to the proximal. So this is posterior displacement of the fracture. That's an example from an X-ray. That's an AP X-ray of the distal tibia and ankle, and that's a lateral X-ray. So the fibula is normally lateral and the tibia is medial, and here's the fracture. And there's some displacement of the fracture. Which side is displacement? It's lateral displacement because the distal fragment is displaced laterally. And on the AP view, that's anterior or ventral, and that's posterior or dorsal. And there is, again, posterior or dorsal displacement of the fracture. What does angulation of the fracture mean? It means tilting. So if you look at this diagram, there is some tilt at the fracture site. And again, we describe it in relation to distal fragment. So the distal fragment is laterally displaced. That's medial and that's lateral on an AP view. So there is lateral displacement, or lateral angulation or lateral tilt. That's another example where there is medial tilt or medial angulation. On the lateral view, that's anterior and that's posterior, so there is anterior tilt or anterior angulation of the fracture. That's an example of the distal radial fracture on the AP view. It doesn't look angulated on the AP view, but look at the lateral view. That's the distal fragment, and that's the proximal fragment. So the distal fragment is relatively posteriorly or dorsally angulated. That's a dorsal angulation. That's a famous fracture, impacted dorsal angulation, a fracture of the distal radius. It's called the Cooley's fracture. Articular surface involvement. You have to comment on whether there is or there is not involvement of the articular surface. If the fracture is involving the proximal or distal end, you have to say whether it's involving or extending to the articular surface or not. That's an example. That's a proximal tibial fracture, but it's extending to the articular surface, to the tibial plateau. So that's an intra-articular fracture of the tibial plateau. And that's another fracture of the distal radius, but there is some extension to the articular surface. So that's an intra-articular fracture of the distal radius. Closed or open fracture. What does that mean? The open fracture is the fracture where there is a wound overlying the fracture. So what does that signify? It signifies that the fracture or the bone would be in direct communication with the surrounding environment, and that would increase the risk of infection and cause some problems in healing. So we have to comment on that. Well, clinically, it's sometimes easier than on X-ray. We see the fractures on X-ray. You don't always see on the X-ray the disruption of the skin, but clinically you can see it. So if you see a fracture and at the site of fracture, clinically you have a wound that's an open fracture. Okay, so we have gone through the points in describing a fracture. So let's practice describing a fracture on this X-ray. So that's an X-ray of the tibia, that's an AP view, and that's a lateral view. The tibia and fibula are both broken, but let's focus on describing the tibial fracture together. So the site, which side is it? It's the right side. And what bone is it? It's the tibia. And what part of the bone is broken? It's the distal tibia, so right distal tibial fracture. Okay, the direction of the fracture, it's a transverse fracture. Is it comminuted? Yes, because I've got 1, 2, at least 3 fragments, so it's a comminuted fracture. Is there any displacement? Yes, there is not proper alignment between the both bones. So on the AP view, there is medial displacement. And on the lateral view, there is posterior displacement. So there is mild medial and posterior displacement. Is there any significant angulation? I don't think so. Is there articular surface involvement? Actually, this X-ray is inadequate because it should have covered the ankle, but the fracture does not seem to have any distal extensions, so most likely no articular surface involvement. Is it a closed or open fracture? On this X-ray, we don't see any evidence of breaking through the soft tissues, but still clinical evaluation is critical. So when you review the X-rays, you have to review the patient clinically to see if there are any wounds overlying the fracture, but it's most likely a closed fracture. So that's an accurate description of this tibial fracture. Dislocation and subluxation of the joints. This diagram shows normal articulation between the two parts of the joints, whereas normal continuity between the two articular surfaces. When there is partial loss of the continuity between the articular surfaces, it's called a subluxation. Where there is complete loss of articulation between the articular surface, it's called dislocation. These are some examples. So that's a lateral X-ray of the elbow joint, humerus, ulna, and radius. Normally, the humerus would articulate with the ulna over here, but what happened? They are not articulating anymore. So how would I describe this dislocation? Again, we're always describing the distal bone. So the distal bone, which is the ulna, is posteriorly dislocated compared to the humerus. Again, there is a finger X-ray, that's the little finger, and that's the proximal interphalangeal joint. There is dislocation. So the distal bone, which is the middle phalanx, is medially dislocated over the proximal phalanx. That's the AP view. And on the lateral view, the middle phalanx is dislocated posteriorly compared to the proximal phalanx. So it's medial and posterior dislocation. That's the left shoulder joint. Normally, this humerus should articulate with the glenoid over here, but then it lies anterior and inferior to the glenoid. So this is anterior and inferior dislocation of the humeral head. Role of CT in trauma. Do we need CT in trauma? Yes, we do, but not in all cases. These are some examples. When we saw some long bone fractures, like the humerus and the tibia and the phalanges, it's sometimes easy to see the fracture lines. But when you have some bones with complex appearance, like the pelvic bones or the vertebral bones, they are composed of multiple bones that are united together. So it has a complex shape. So CT would be useful in evaluating these bones. Also, when you see a fracture line, but you cannot completely determine if it's extending to the articular surface or not, like a pelvic bone a fracture that you're not sure whether it's extending to the acetabular region or not, then the CT would be helpful. Visceral injuries. For example, you have got a patient with multiple rib fractures and he's got some abdominal pain. So you would want to exclude underlying visceral injury, which could be a splenic or liver injury, and X-ray won't detect these. So you would do a CT to exclude underlying visceral injuries. Patients with severe injury, like those with severe road traffic accidents, the CT is sometimes the modality of choice, and it would replace the X-rays because first of all, it's quicker because you can take the patient to the CT scan and scan his heads up to the pelvis bones, head, neck, thorax, abdomen, pelvis, in about 5 minutes or less than 5 minutes. 5 minutes for organizing the scan. I mean, it's very quick. And you don't need to move the patient a lot. I mean, in X-rays, for example, if you want an AP and lateral view, you have to move and manipulate the patient several times to obtain an AP and lateral view of each joint. But on the CT, the patient just lies on the CT scanner and takes the whole scan, and then we do the manipulation for him by instead of the manipulation, we do that by software, and we do reformatting of the images in sagittal or coronal planes, but you don't need to move the patient, especially if he is severely injured. That's an example of a CT. On this pelvic X-ray, there is suspected some sharp angulation in this acetabular region. So if you do the CT to confirm, there's an obvious and clear fracture line confirmed on the CT. MRI. MRI is sometimes indicated in cases of trauma. For example, in cases of severe spinal injuries, when you want to exclude associated ligamentous injury, or if you want to exclude cord compression, you need to do an MRI. Some occult fractures are not obvious on X-rays, and sometimes they are not even obvious on the CT. And in these cases, we do an MRI because MRI is sensitive to bone marrow edema. Examples of these are occult scaphoid and impacted neck of femur fractures. Ligamentous and tendinous injuries are not usually obvious on X-ray or CT. You can sometimes suspect those, but you cannot see the normal full anatomy of these structures on the CT. For example, if you're suspecting an ACL tear, quadriceps tendon tear, patellar tendon tear, you will need an MRI to detect these lesions. That's an example of a cervical spine MRI in a patient with spinal injury. So that's a fracture dislocation of the cervical spine. That's the cord. See how clearly we can see the cord on the MRI. That's the spinal cord. And we can clearly see that this fracture is compressing the cord. And if you look carefully, you'd find that this part of the cord looks different than this. This is brighter, which is, more white than the adjacent cord. And this signifies that there is cord edema and cord injury here. These signs are never that clearly obvious on CT and never, of course, on X-ray. So MRI is very useful in evaluation cord injury and spinal injuries. Another example of MRI, that's an X-ray of the left femur in a patient with trauma. No obvious fracture lines could be identified, but then on the MRI, there is an obvious fracture line that was totally occult on X-ray. That's an MRI of the knee. That's how the ACL, normal ACL looks. It looks like a black oblique ligament extending from the femur to the tibia. Black oblique ligament from the femur to the tibia. This patient with history of trauma and giving way after trauma, knee giving way after trauma, That's how the injured ACL looks like. It's no more that black, and it's lying rather flat over the tibial plateau. It's not stretched and oblique as it used to be. So that's a torn ACL in a trauma patient. Any questions?
Thank you very much for your presentation. That was very, very nice. I can't remember the last time I enjoyed a presentation this much.
You're welcome.
Yeah, I think that was very extensive. What about ultrasound? Any role, or is it just for joint effusion?
Yes, ultrasound is helpful, but the problem in ultrasound that you need an it's sonographer dependent. You need someone that's professionally trained to do the ultrasound, but it sometimes can be very accurate and even more quick than MRI in assessing some soft tissue injuries. I mean, for expert sonographers, you can exclude quadriceps tendon tear, tendo Achilles tear. It can sometimes replace MRI and be quicker than doing an MRI, especially if the MRI is contraindicated in the patient with pacemaker. The ultrasound would be perfect in detecting these lesions, but the only problem is that it needs someone that's really trained to do that.
All right. Okay. And just one more question. When you were describing to adequately describe a fracture, and for example, in terms of the displacement, is it proper terminology to combine the two planes together? For example, to say anterolateral displacement, or
Yes.
that's not? Okay.
Yes. Yes.
Okay.
Yes.
All right. Okay. And yes, we'll ask the participants to see if there's any question. If not, the advantage of this kind of presentation is the session is recorded and people can still log in at different times forever, join in, and then still benefit from this presentation and get their certificates.
Mm-hmm.
So we'll give them just 1 more minute. If there's no question, I think we'll just call it a day then. Yeah, there's a question about if subluxation is the same as angulation.
Okay, so subluxation, we usually describe the joint as subluxation. I mean, it's between two different bones, between the humerus and the glenoid, between the femur and the acetabulum. That's called the subluxation, between two not broken bones, but they are two articulating bones. Angulation, it's the same bone that's broken, and we're describing the humerus, the distal fractured fragment, in relation to the proximal fractured fragment. So subluxation describing a joint abnormality, but angulation describing a bone fracture abnormality.
All right. Okay. Any other question? Yeah, the feedback link will be sent automatically once the program ends. And I think that's all for today. I don't think there's any other question. Thank you very much,
Thank you
Dr.
very much. Thank
Riskala.
you. Thank you.
Okay, thank you everyone for joining. Bye for now.